जो तुम्हाला YouTube लाईव्ह किंवा हे करायला हेल्प करेल.
Perfect. That will be helpful.
We are going live, so please mute yourself.
तुम्हाला YouTube लाईव्ह किंवा हे
We are live.
नमस्कार मंडळी, मी उल्का नगरकर, महाराष्ट्र मंडळ शिकागो 2022 चे अध्यक्ष. तुमच्या सगळ्यांचं महाराष्ट्र मंडळ शिकागोच्या आरोग्य धाम या नवीन कट्ट्यामध्ये स्वागत करते. आपला जानेवारी महिन्यामध्ये प्रोग्राम झालेलाच आहे. आता फेब्रुवारी महिन्यामध्ये आपल्याला वक्ते म्हणून लाभलेले आहेत डॉक्टर सांबारे, जे आपले शिकागोचेच रहिवासी आहेत. आणि कार्यक्रमाला आपण लवकरच सुरुवात करूया. यावर्षीचे आपण नवीन 3 कट्टे सुरू केलेत, आरोग्यधाम, अर्थविचार आणि भ्रमणगाथा. त्यांना तुम्ही भरभरून प्रतिसाद द्या आणि यातील जी सेशन्स आहेत त्यांचा आनंद घ्या आणि आम्हाला त्याचा फीडबॅक नक्की द्या. आता मी आरोग्यधामची जी ऍडमिन आहे डॉक्टर दीप्ती भाले गोवर्धन, हिला आपल्या हातात सूत्र घ्यायची विनंती करते. दीप्ती.
थँक्यू उल्काताई. तर नमस्कार मंडळी, मी दीप्ती गोवर्धन तुमच्या सगळ्यांचं आरोग्यधामच्या लाईव्ह सेशन मध्ये स्वागत करते. आजचा विषय आहे लिव्हिंग विथ डायबिटीज आणि आपल्याला याबद्दल माहिती देणार आहात डॉक्टर दत्ता सांबारे. So he has been practicing as a primary care physician, internal medicine in Bolingbrook, Illinois for almost 25 years and is certified by American Board of Internal Medicine and American Board of Obesity. तर डॉक्टर सांबारे, मी तुम्हाला निमंत्रण देते की तुम्ही कार्यक्रमाची सुरुवात करावी. Over to you.
Is that for me now?
Yes, sir. You can start.
Good afternoon, ladies and gentlemen. Talking about one of the most common conditions that we see in medicine every day, in daily life. Not just in medicine, it affects the general public in your daily life as well. So knowing about diabetes is always good. The more we know, the thing we realize how less we know about it. And things have been developing over the past several decades. And diabetes, the information about diabetes has spread widespread mainly because of the social media as well. And the knowledge is so much widespread and so many people know so much about diabetes now that the other day I was talking to one of the persons. The person indicated to me that, what new are you going to say about diabetes, doctor? Most of the people know everything anyway. But it's always good to refresh about diabetes and relearn about diabetes. Maybe I will be learning a little bit more about it and help myself in my practice by this session. So let's start to discuss something about diabetes, and I'll try to say as much as I know about it. Can we move on to the next one, please? Diabetes mellitus. What is diabetes? Diabetes is a metabolic disorder, is a chronic metabolic disorder, which is characterized by elevated blood glucose levels in the body, either due to insulin deficiency, impaired action of insulin, secondary to insulin resistance from the host, or both. Usually we have one or the other, but sometimes we can have both of them together. So either there can be a total insulin deficiency, that is, the body is unable to produce insulin, and there is total lack of insulin in them. These patients are called type 1. We'll talk more about that later on anyway. And then there is the other one, that's impaired action of insulin, which is referred to as individuals developing resistance to the action of insulin, causing elevated blood sugars. or there can be a condition both together. Some people are like, have this kind of situation. Then apart from diabetes, we have another class which has been recently talked about and developed as a category because of the higher risk of these individuals, these set group of individuals developing or who go on to develop diabetes later on. And this is called as prediabetes. What is prediabetes? Prediabetes is elevated blood glucose levels in individuals which are below the diagnostic levels. And this may be the time where the insulin resistance is developing, or it has already developed, or it's slowly increasing. And a small trigger, some kind of a trigger, may push these individuals or these set of individuals into a full-fledged frank diabetes mellitus type 2. Can we move on to the next one, please? So, knowing a little bit about history of diabetes. History is almost always interesting for any kind of thing. In diabetes also, there is interesting aspects of history that we can learn. Diabetes, as I was telling you, is one of the oldest diseases known to mankind. It probably has been there before that, before we knew it, obviously. As early as 1550 before Christ, that is 3,500 years ago, Egyptian physicians, Hera, that's the name of the physician, Hera, who described an individual or individuals who were seen as emaciated individuals with increased thirst, drinking water all the time or drinking fluids all the time, and frequent urination. So these three things, these three features are very classical of diabetes, as we will talk about that more and more. So this has been mentioned in as early as I mentioned, 1550 BC. Not much was done at that time. It's just a description that they found. And then that continued on later, about 1,000 years later, which was before the Christ again, 500 to 600 years before Christ. Sushruta, the well-known Indian physician, Ayurveda physician and surgeon, actually, he's the person who is credited to be doing surgery in those days, in those years. So he's called as the first surgeon also. So Sushruta described the condition of diabetes, similar to diabetes. He didn't call it as diabetes, but he described the condition of sweet urine and sticky urine, honey-like urine. That's why he named it as Madhumeha. So this Madhumeha, before this, Madhumeha was coined by Sushruta. They used to call it as Prameha. Prameha is passing. And Madhumeha is sweet urine. So this kind of description of individuals went on, and probably the world was passing through wars and famines, and not much was looked into this condition. Probably there was not much incidence also. And later on, as late as 1640, 1641, and 1889, these are the two years when the scientists, physicians developed a relationship between increased blood glucose levels and pancreas. So these physicians at that time, they did surgery, resection of the pancreas from the dogs, and those dogs later on became diabetic. So this is the kind of development of diabetes that went on, but it was still considered as a disease. And there was an observation also, a disease where people have increased thirst, increased urination, and the people whose urine attracts ants. That's how that was looked at. And as it went on, later at the turn of 1800, 1900, people started looking at that as a disease with early detection, and think of some treatment for the diabetes. And that time, the diabetes treatment included just diet. If a person is losing more sweet in the urine, sweet substance in the urine, let him eat more so that the loss will be compensated. That was the thought. Then someone else did, okay, let him not eat more. He's losing more in the urine, so let him not eat more. And that kind of situation where they tried to fast the individual or restrict the individual's food, that person did much better than the person who was fed more. So that's a kind of interesting observation around the late 1800s, 1900 times. Can we move on to the next one, please? Can we move to the next slide? So later on, as the world developed and as food became more and more available, particularly after World War II, when everything became plenty, everything became abundant, food became abundant, particularly in the United States and Western Europe, where the land of abundance, as US is known, food became available, and that led to the prosperity and obesity of individuals, and also the increase in the incidence of diabetes. The prevalence of diabetes started increasing. The current situation is about 37.3 million people have diabetes in the United States, which is 11% of the total population, which is highly significant. 1 in 10, 1 in 11 has diabetes. Then if you see that in age distribution of the population, then you will see even more stark observations. The diagnosed people are about 28 million, as you can see here, and undiagnosed about 8.5 million. Then 96 million people are supposed to have pre-diabetes. They are not tested because they may not go to the doctor. So that makes it about 38% of the adult population over the age of 18 has pre-diabetes. Now, if we measure only to the 65 years and older, then that's about 26.4 million, 26.5 million people, which is almost half of them, 48.8%, which is roughly half of the people over the age of 65 have pre-diabetes and diabetes. That's how massive the problem is. And that's why diabetes mellitus is being called as an epidemic right now. Next one, please. Now here I wanted to show you the prevalence of diabetes. As I was telling you earlier, the incidence was not that high. If you go back to, this is 1985, before 1985, this is the number in millions. This is the year. So before 1985, the incidence was way below, up to 20 million people in the world. That slowly increased, and around the turn of the millennium, when it was about 100 million people, in the last 20 years, this has gone from 100 to 125 million to almost 300 million people. It has more than doubled in the last 20 years. And if you look at the graph, this doesn't seem like it is plateauing. It seems like it is still going up. Unless something seriously is done, this is likely to go even further and worsen the situation even more. And that's how serious the problem is for diabetes. And something really needs to be done on war footing basis, the way this is going on. And it becomes everyone's responsibility. Obviously, it is individual responsibility as well, but it's a community responsibility too, government's responsibility too, to do something and frame the policies accordingly. Can we move on to the next one, please? Now, when we look at the prevalence and see the distribution in the population demographics, we look at that, the ethnic distribution is a little bit varied. The Caucasian population is less affected compared to the other ethnicities. And if we look at that, the Native Americans are the highest with 14.5%. The Asians, particularly here, we are here, Asian Indian, 12.6% total prevalence in population. And in men, it is 13.9, women, it is 11.1. So what does that tell you? It is almost equally distributed in men and women. Both are equally affected. And then as you go down, you can see in the other population as well, other ethnicities as well. Can we move on to the next one, please? Now, coming to the economics of the problem of diabetes, of healthcare expenditure on diabetes. Currently, if you see, for every $4 spent, $1 is spent on diabetes healthcare. So 25% of the healthcare expenses happen to be on diabetes care. And the direct cost for the government is $237 billion each year. $237 each year may not be the total budget of some of the nations. And here we are spending every year on just one disease, management of one disease, with the problem still getting worse. And this increase, surprisingly, and it has been 60% of the increase has been in the year 2007 to 2017, and it's likely to go up even further. Well, that's about the community. What about the individual? An individual who is suffering from diabetes, or who has diabetes, or who has to take care of his diabetes, or another family member in diabetes, they tend to have an expense of $571 per month. And on average, some obviously will have more, and translated to $6,852 per year. Now, this may not, to the younger people who are employed and investing in other areas, it may not sound as much. But for those who are 65 and older on fixed income, that's a huge chunk of their income, huge chunk of their revenue per month that is spent on just diabetes only. And there may be other problems too to look at. So how to improve upon this situation? Can we move on to the next one, please? How to improve upon this situation is what we need to do, what we need to learn. And it's certainly helpful for everyone to do their part, at least for individual gain, if not community gain. Now, coming to the symptoms of diabetes, most of you know the symptoms of diabetes are increased thirst, increased hunger, frequent urination. But most of the times, there are no symptoms. Usually, on routine exam, someone is diagnosed to have diabetes. And that's the most common scenario. Certain uncommon situations are, we come to know about diabetes in an individual when they present with blindness or blurred vision. Blindness is extreme, but that does happen. Then stroke, a sudden presentation as a stroke, instantly making a person disabled, can be a very dramatic presentation of diabetes, because that's the time blood sugar gets checked and we come to know that the blood sugar is 500 and the individual is diabetic. Or the other thing that can help find or diagnose diabetes is delayed healing of wound, or a wound does not heal. Some small cut on the foot or in the hand, and that kind of spreads, does not heal right. That is because the blood sugar in the individual is high. And that kind of leads to infection. I remember when our professor used to say while I was in the medical wards as a student, my professor used to say, the wound doesn't heal because the blood of that patient, diabetic patient, is like ice cream to the bacteria. So the bacteria get attracted to that. And that's why the wound does not heal, because that gets infected very quickly. All right, can we move on to the next one, please? Can we move on to the next one?
Doctor, I'm on diagnosis slide. Is that what you want?
You're on diagnosis slide. Yes, okay. So what was the one before that? Can we go back one? Symptoms. Okay, so we can move on to the diagnosis. So knowing these symptoms, we can talk about the diagnosis. There are very few tests that can be done, that need to be done to diagnose diabetes. Now, the age-old test is glucose in urine. Now, 3,500 years ago, people knew that person's urine is sweet, so there is something abnormal. 2,000 years ago, they knew that ants get attracted to the urine, so obviously there is something abnormal there. And urine is sweet was described 2,500 years ago. So glucose in the urine is classical of sugar and diabetes in an individual. But it's not very reliable. As time went, the physicians and science worked on, and they developed better tests. And in the quest of better tests, they came up with blood glucose or blood sugar. And then they realized about fasting blood sugar and the concept of postprandial blood sugar. So for nearly 40, 50 years, the two tests that were used were fasting blood glucose and postprandial blood glucose. And in between, they came up with another type of test, which is glucose tolerance test. So let's talk about fasting blood glucose. Fasting blood glucose is after at least 8 hours of fast, eating nothing or drinking nothing except water, and then check the sugar. If the blood glucose or blood sugar is 120, more than 126, that's considered as diabetes. And postprandial, which is also called random, by the way, postprandial or random, if it is more than 200, then that's considered diabetes. Generally, people tend to do it at two different times, particularly for fasting and postprandial, just to be sure, because you don't want to give a diagnosis to an individual which is going to be with that person for the rest of his or her life. So you want to be careful with that. And that's why on two different occasions, at least 1 week apart, you want to do a fasting blood glucose with at least 8 hours of fast, or postprandial blood glucose 2 hours after eating. Again, two separate occasions, 1 week apart. The third one is the glucose tolerance test. Now, what is glucose tolerance test? It is a combination of the two, fasting as well as the postprandial. So you go to the lab fasting, and then they'll give you a bottle or a glucose load to drink. Before you drink, they'll check the blood sugar, which is a fasting blood sugar. And then at 30 minutes, 60 minutes, and 120 minutes, which is 2 hours, your blood sugar will be checked. And if at the end of 2 hours, your blood sugar stays above 200, then that's diabetes. But if it stays above 180 and in between 180 to 200, that will be considered as impaired glucose tolerance test. And above 200 is abnormal glucose tolerance test. Now, another test, as you can see, these three tests were there, but they were not very reliable. They were not simple. An ideal test for any condition, an ideal test is that can be performed very easily. It's not cumbersome to perform, and it's very easily reproducible, and it's very cheap. So those three things were not fitting. Like fasting, person has to fast for 8-12 hours. Postprandial, then you have to eat and then go 2 hours later. So these are some of the things that were kind of causing hindrance. And that's why the other test, that is the hemoglobin A1c, was developed. Now, currently, hemoglobin A1c is the one that is being used commonly, and on a regular basis. Those who have diabetes, they probably know it very well. What is your A1c is the question that doctor asks all the time. And most of the patients know what is A1c. And that has become the standard of care for diabetes nowadays. So what is A1c? A1c is the hemoglobin concentration over the last 3 months. Why last 3 months? Because the lifespan of the blood cells is that, and that's why you get the glucose, that is glycated hemoglobin, glucose attached to hemoglobin, that lasts in the blood for about 3 months. So you get the glycated hemoglobin, means average blood glucose level for the last 3 months. So if we do it today, which is 27th of February, from 27th February to 27th January to 27th December and 27th November. So in the last 3 months, which is very useful for prognostication or understanding the effect of treatment of the individual as well. That's why it has become very popular nowadays. So most of the times we go with hemoglobin A1c. Can we move on to the next one, please? Coming to the risk factors. What are the different risk factors that lead to or that increase the risk of diabetes in individuals? One is BMI. All of you might have heard or are aware of what BMI is. BMI stands for body mass index. So more than 25, body mass index of more than 25. So higher the body mass index, higher the risk of diabetes. Then physical inactivity, that's another risk factor. High risk race or ethnicity, which, as we have seen in the previous table, we certainly fall in that category. So just by being ethnic Indians, Asian Indians, we fall into the high risk category for diabetes. You don't have to do anything else. Just born as Indian or Indian ethnicity is good enough. Then the next one is high blood pressure. Persistent high blood pressure, more than 140/90, is a risk factor for diabetes. And the next one is gestational diabetes. If during pregnancy, a woman has diabetes, gestational diabetes, she has a higher risk of developing diabetes later on in life. Then the next one is low HDL. HDL is considered as high density lipoprotein, is considered as a good cholesterol. If that level is low, lower than 40 in case of males and lower than 50 in case of females, that is considered as a risk factor for diabetes mellitus. Certain medications for some other conditions, if we are being treated for, they are also a risk for diabetes. Here, I would like to mention steroids is one. And, in the last 2 years, we are facing this problem of COVID, the COVID pandemic. Unfortunately, the treatment for COVID in the hospitalized patients, we have to give them dexamethasone, which is a steroid, and that is given for 10 days at least, and in 10 milligrams daily dose. Patients who are already diabetic, their blood sugar gets worse. And we keep watching that. Obviously, we have to give insulin in the hospital, but that's an unintended consequence of the treatment that we see. So the steroids is one of the medications that can lead to diabetes. Then there are some other medications, and some of the medications are used in the treatment of mental health disorders. They can lead to diabetes too. Heart disease is a risk factor for development of diabetes. Then obesity. We'll talk more about the obesity and diabetes later on as we move on. Can we go on to the next one, please? Now, we were talking about the BMI, body mass index. BMI was first developed as a tool for demographic studies or statistical purposes by a Belgian mathematician. And body mass index, or BMI, is a ratio of body weight in kilograms divided by height in meters square. And that's the ratio that you get. And it is divided like this, as you can see on the screen. Underweight, below 18.5, it's underweight. And the risk, if the BMI is too low, that is less than 18.5, has a health risk, which is moderate. Then the next group is normal. 18.5 to 24.9 is normal. Here, there is obviously a minimal health risk in this group. Then overweight, from 25 to 30, that if the BMI is in that range, the health risk is moderate, and the group is called overweight. And anything above 30 is considered obese, and above 35 is morbidly obese. Can we move on to the next one, please? So here is how it works for the body mass index. Less than 18.5, as you can see here, which is underweight, which is reflected in the body image. Then the normal age, normal BMI group, 18.5 to 24.9, 25 to 30 or 20.9, 29.9. This is the group where the health risk or health hazards begin. The risk begins in this age group on, and it keeps on going up. This is about the female population. Can we move on to the next one, please? And this is the male population. And as you can see, the typical Indian, ethnically Indian group, most of them usually you see in this category of 25 to 29. And when we talk of Indian population, the body mass index, what is being used here, this is more for American population. If we have to use it for us, for Indian population, you have to go a little bit lower. So even if you are, let's say 24 or 23, 23.5, so even in this group, we will be in the overweight category. And in India, I was talking to some of the friends of mine. He is a cardiologist. I learned the term lean obese. So they call them lean obese. The reason being the waist circumference is high, and otherwise the arms and legs, they are fine, but the waist circumference is high. So that's why the risk is very significantly higher in this population. And the body mass index may be in the normal range, like in this category. Let's move on to the next one, please. Now, this is a graph I wanted you to see, which is reflecting the health risk or health hazard based on the BMI. As you can see here, a lower BMI after 18.5, lower than that, the risk of health risk or health hazard risk actually increases. And this is green, as you see here, green, this is in the normal range. So 19 to 25, you are in the normal range. And then as you cross 25, it keeps going up and it further goes up. The risk multiplies 1.5 times, 2.5 times, like that. And as the BMI goes up 35 on, it's even worse. Okay, next please. And here I wanted to show the relationship of health hazard or risk of disease and BMI, which is translated into overweight or obese. This is affecting almost every organ or every organ system, starting with bones and joints, early development of osteoarthritis, then heart disease, that's well known, gallbladder disease, gallstones, that happens very commonly in these individuals. Then nervous system, strokes. And this another condition here, as you see, sleep apnea. This is not a well-known condition or well-recognized condition, but this happens more in obese individuals. Obstructive sleep apnea, which is snoring and choking during sleep. And they may need CPAP machines, or majority of the times just losing weight helps them with this condition. This is one of the reversible things in the treatment of obesity. And then these diabetes. Can we move on to the next one, please? Here, this is a Venn gram. Let's say this is diabetes, this circle has diabetes, and this circle has obesity. Not every obese individual is diabetic, and not every diabetic individual is obese. So that's why I wanted to show this one. But there is an overlap. The overlap is actually much more than what is shown here. It should actually be coming like this, almost half of that. So half of the individuals who are obese are likely to have diabetes, and half of the diabetics are likely to be obese. That's how I wanted to show, but I couldn't find that. But this is at least a representative of that. Okay, next one, please. Here I wanted to talk about a condition called metabolic syndrome. Metabolic syndrome is not an exact disease as such, but it's a syndrome, as you can. It's a symptom, not even a symptom complex. It's a collection of several factors which are risk factors. And these individuals in this category are not really healthy and at high risk of developing diabetes and any other diseases like heart disease or central nervous system disorders as well. And what are these? One is waist circumference. Waist circumference in men, more than 35 inches or 89 to 90 centimeters in men. Actually, the numbers are described as 40 inches in the American standards, but for Asian, they specifically mention about Asian American individuals, it should be considered as 35 inches in men, 31 inches in women. Triglyceride level. I guess you all know that lipid panel includes triglycerides as well. So the triglyceride level of more than 150 is considered as a risk factor in metabolic syndrome. Or if you are on medication for lowering triglycerides, then the HDL cholesterol level lower than 40 in men and lower than 50 in women. Or if you are on medication or on treatment for increasing the HDL levels. Then the blood pressure level, systolic, which is the upper blood pressure, more than 130, and diastolic, or the lower number, less than 85, and the fasting blood glucose of more than 100. So these 5 factors are together. If you have 3 out of 5, you are considered to have metabolic syndrome. Any 3 out of 5, particularly waist circumference is the most common one. Next one, please. Now, coming to the complications of diabetes. Diabetes is a multisystemic disease, is a chronic disorder of metabolism. Diabetes can affect almost every organ in the body. It's considered as a model disease. It can cause complications in the cardiovascular system, heart attack or heart failure, congestive heart failure, or the coronary artery disease and heart attack, myocardial infarction because of the blockages. Second, in the brain or central nervous system, stroke, which will cause instant disability depending on the severity of the stroke. There can be multiple small strokes as well, which can lead to the condition dementia later on. And then kidneys. Patients can end up in having kidney failure, ending up on dialysis. You might have seen, or you might be knowing a person who has had any of these conditions. Then eyes, cataract. Patients with diabetes tend to develop cataract at an earlier age. It can develop in the age of in their 40s, late 30s, or even 40s. Or the retinal damage. You might have heard people having laser therapy, laser treatment for retinal damage. Then the legs, circulation to the legs, causing wounds which are not healing because of lack of circulation, poor circulation. And diabetes by itself can do that, leading to amputations. Or smoking can do that. And smoking and diabetes together will cause even more. There are very high number of amputations that go on even today because of uncontrolled diabetes and peripheral arterial disease. People losing their foot, people losing their limb and getting disabled. Then continuing with the nervous system, nerves, peripheral neuropathy. You might be having a condition called peripheral neuropathy or burning feet syndrome. Burning pain, lack of sleep because of the pain. That's a very disabling condition as well. And that again develops because of uncontrolled diabetes or sometimes because of borderline diabetes over a long period of time. Even the diabetes is reasonably well controlled, but they still develop that. So sometimes these things depend on the age of diabetes rather than the controlled or uncontrolled diabetes or the severity of diabetes. The next one is fatty liver. Now, this one, I wanted to stress on this because this can lead to a condition of cirrhosis of liver. Cirrhosis of liver is scarring of liver, which most commonly happens with alcoholism, chronic alcoholism. But individuals who have diabetes have never had any alcohol, but their diabetes is not well controlled for many years, can develop this fatty liver. And then the accumulation of fat in the liver causes displacement of the natural cells, leading to inactive cells, leading to further inflammation in the cells and scarring, further causing advanced cirrhosis in them. And that has its own complications. So that's one thing that we need to be careful about and control the diabetes as much as possible. And lastly, another symptom that usually is seen in younger population is sexual dysfunction. Now, this can be a presenting symptom as well, typically happening in 35-year-old, 40-year-old male. He does not know that he has diabetes. And because of diabetes, the condition develops sexual dysfunction. And that's how he presents to the physician. That's how he gets diagnosed. And control of diabetes, treatment of diabetes and control of diabetes improves the situation. So these are some of the complications. This is obviously a long list, but not a complete list. Can we move on to the next one, please? Now, Here is another complication of diabetes, more of diabetic treatment of diabetes rather than diabetes itself, because diabetes itself is high blood sugar. But here I'm talking about the complication, because I want every single person with diabetes to know that there is something called hypoglycemia or low blood sugar. If you are on medication for diabetes, you must know or be aware of hypoglycemia, because each and every medication for diabetes can lead to the complication of hypoglycemia, particularly if you are trying to have a strict diet, particularly if you are controlling your calories, not eating well, for some reason you don't eat and take your medication, insulin or some other medication, you can develop low blood sugar and cause hypoglycemia. What are the symptoms of hypoglycemia? We feel shaky, tremors, confused, feel sweaty, dizzy. There is a sudden change in the behavior. Person is talking fine and suddenly starts getting rather confused and irrelevant, and so becomes very lethargic, drowsy. The earliest symptom of that hypoglycemia is you start feeling very hungry, abnormally hungry. The extreme situation of this hypoglycemia is coma. Patients can go in coma and the damage can be irreversible because of hypoglycemia. You know, when we see some dramatic events, even this happens to most of the medical students, when we see some kind of dramatic situations, those kind of patients stick and live with you for the rest of your life. Similar thing has happened to me. There was one patient who was on insulin in the hospital and was given insulin. After that, the patient was given a tray. Nobody noticed that the patient did not eat dinner, got insulin, and then the blood sugar went down. Around 1 o'clock or 2 o'clock, probably the blood sugar went down till 6 o'clock in the morning. Nobody noticed. And after that, the patient became comatose, and that was an irreversible situation. The patient never woke up. And that has stuck in my mind. I'll probably never forget that. And that's why I always want to make sure that every diabetic patient knows what hypoglycemia is and how it is detected early, realized early, and act on it. Okay. Next one, please. Okay, having talked about the symptoms and the presentation and the health hazards of diabetes and the complications of diabetes, we need to come to, okay, we know the problem now. We know that the problem is big. We know that it is problematic. What to do about it? We have to do something. So what can be done? For any condition, not just diabetes, for any condition, the line of action can be, or line of intervention can be, prevention of the condition, early detection of the condition, limitation of the disability, and treatment or rehabilitation of the individual. We have to talk in those lines. So coming to prevention is always important. Do everything and prevent whenever possible. And the other part is diet and exercise. You'll probably hear this from every physician or every healthcare provider: diet, diet, and diet. The treatment of diabetes is diet, diet, and diet. It cannot be overemphasized. No, we cannot overemphasize the importance of diet. We are what we eat. As simple as that. And the next one is exercise, exercise, and exercise. We don't need to talk about the medications. Medications come last. We want to avoid medications as far as possible, as long as possible. And even if one gets 2 years, 5 years without medications, that's healthy life for that many years. one more day without medication is one more day without medication. That's how I want to look at that. And I want to help every patient to understand this, that diet is one of the most important things in your life, and diet can help you avoid developing diabetes itself, help you to control diabetes, and help you to prevent the complications. So what about the diet? Having talked so much about the diet, what is the ideal diet? And what should we do? Let's move on to the next one. Our diet, the food we eat, is mostly the next few things that I'm going to talk about. Carbohydrates. Carbohydrates, proteins, and fats. These are the three things that we eat mostly. Of which carbohydrates are the ones that we eat the most. All of us, what we eat, the snacks that we eat, the food that we eat has mostly the carbohydrates. And carbohydrates are essentially sugars. They are simple sugars, they are complex sugars. Carbohydrates are abundant, they are abundant and available in plenty, cheap as well as profitable. Because they are cheap and profitable, people want to sell them to you. That's how McDonald's wants to do it. That's how Burger King wants to do it. And that's how our Indian restaurants want to do it. They want to give you lot larger portions and keep you well-fed and happy so that you go back to them again and again. So the carbohydrates are simple sugars like the glucose or our sugar that we always use. That then starch, the complex sugars, which is what we see in rice, bread, chapati, paratha, naan, and potatoes. And the third thing about carbohydrates is fiber. Fiber is starchy fiber and digestible fiber, and non-starchy, non-digestible fiber. So this is about carbohydrates, and these can be vegetables, these can be cereals, these can be processed foods. Mostly the processed foods that we eat are carbohydrates. Next, please. Proteins. The source of proteins is animal protein, dairy protein, vegetable, and beans. Fats is oils, vegetable, animal, and dairy fats. Now, micronutrients is one thing that I want you to understand, which is vitamins and essential minerals, which are usually found in most of the foods that we eat, particularly the vegetables and fruits, and also the fats that we eat will give you vitamins and essential minerals. The other thing that we don't talk about, which should be talked about, is water. Each one of us should drink enough water, which most of us don't do. The recommended daily intake of water is 64 ounces. 64 ounces of water every day. If you really drink that, that will automatically help you eat less. Try it a few days and see what I'm saying is right. Okay, next one, please. So the recommended dietary intake by American Diabetic Association is for this happens for particularly for diabetes, 1800 calories per day. So the total daily intake should be 1800 calories or less. This is American Diabetic Association recommendation. It includes carbohydrates, proteins, fats, essential foods. But mind you, everything counts. Everything that you eat counts. And it also includes the alcohol intake as well. Alcohol also gives you calories. So that needs to be included in this as well. But when we come to the Indian ethnic population, the recommended diet, particularly for diabetes, should be between 1200 to 1600 calories. It should not be 1800 calories. 1800 calories is still high for Indian ethnicity. Next one, please. So the ideal diet I was talking to you about is not what we see here. This is not what we should be eating. Okay, this is just to show that this is not an ideal diet. Next one, please. So to get the idea of what we eat regularly and how many calories that we have, me and my wife, we did this at home. This is the container that we used. This container weighs 50 grams, and the same container we use for different things that I'm going to show you now. So this is rice. If you take away, this shows 187 on the weighing scale, take away the 50 gram for that container. This is 137 grams, which roughly comes to 250 calories, or the amount of rice that we have in this. Next one, please. Now, this is the fulka. These are two fulkas weighing 67.5 grams, and the approximate calories that you get from this is 160 calories. Okay, next one, please. Now, this is potato, the potato curry or aloo sabzi. This also can be used for the batata vada, which typically we love to eat. The amount that is shown here, 180 grams, again, take away the 50 grams for the container, which is 130 grams. Now, this 130 grams is roughly giving you 250 calories. Now, this is only about the potato here we're talking about. Now, the vada pav that you have is going to add for the bun that you are going to eat. So the bun will roughly give you another 60 to 80 grams. So if you have two vada pav, that will give you 250 plus another 150, let's say 400 calories just with the two vada pav. And that clearly is not sufficient to satisfy the hunger most of the times. Next one, please. And this is the amount we see with pohe, 177 grams. Take away the 50 grams, so 125 grams roughly, giving you 200 calories of carbohydrates. Next one, please. This is the beans. Now, this one is giving you 170 grams of beans, but this amount of 170 grams of beans is giving you roughly 18 grams of protein. I repeat, 18 grams of protein. I'm stressing that because here is the shift. I'm not talking more about the calories here. I'm talking more about the proteins here because of the high protein content and the advantages of eating beans more in your diet is a high amount of protein and also the other nutrients that you get, the essential nutrients and the micronutrients that you get from beans. Next one, please. Here are some information about water. I said 64 ounces of water. What is 64 ounces? This one full jug of water is 64 ounces. We are expected to drink this much in a day. Every day, unless you have been advised by your doctor to restrict your fluids for whatever condition it may be. All healthy individuals with healthy kidneys should be drinking 64 ounces of water. Or if this is 8 ounces, so 8 cups of water in this. Next one, please. This is a 64 ounces bottle. The total, when it is full, 64 ounces. So drink one full bottle every day of water. Next one, please. Now, coming to the vegetables, fruits and vegetables. These are complex starch, fiber, micronutrients, the tomatoes, the berries, the peas, the lentils, the carrots, the cabbage. This is what is going to be giving you the essential foods, enough calories, and this should be plenty in our diet. Even if it amounts to replacing the rice or the chapati, that will still be healthy for us to eat and substitute the rice with this kind of food. That is the lentils, beans, and fruits and vegetables. Next one, please. So here I wanted to show you something. This is fruits and vegetables that I was talking about. If you eat vegetables, fruits and vegetables worth giving you 400 calories, it will fill your stomach completely. So for the next 4 or 5 hours, you won't feel hungry. You will have the satiety. When the stomach is full, that's when the brain has the signals and you get the stimulation or the feeling of satiety and don't want to eat anymore. Whereas with 400 calories of beef or chicken, this part is only, stomach is only half full and you still feel hungry. So you eat more. And by the time you get that satisfaction or full stomach, it might be 1,000 calories or even more. Next one, please. This is a comparative graph of how the stomach is full and the satiety by vegetables, veggies, and fruits. Here, these potatoes and whole grains with 400 calories. Even with 400 calories, it's better than others, but it's still not full. With meat, it's less than half full. With the processed junk food, the processed food, 400 calories will be just this much. And this is oil and fat, which is totally empty. Now, this gives you an idea of what 400 calories can do depending on the type of food that you eat. And that's why you need to be choosing it the right way. Next one, please. Now we come to the topic of glycemic index. When we talk of different foods that the individuals should eat, why we try to tell about, or why the doctors or the dietitians are motivating you to eat more rice, not more rice, less rice, more beans, more vegetables, more fruits, is because of this glycemic index. What is glycemic index? Glycemic index, as the name suggests, it's a ratio. It's a ratio of a relative absorption of the food and the rise in blood glucose levels by a particular food in relation to glucose. So that number runs from 0 to 100. And whatever the blood sugar raise happens by eating just 100 grams of glucose is given the number 100. And rest of the foods are in relation to that. That's why it's a ratio. So that's a glycemic index. For some foods like rice, bread, potato, as we'll see in other for subsequent slides, the glycemic index is high, and that's why the blood sugar rises significantly higher, even with the normal meals that we have, and then comes down slowly over the next 2 hours. And then before it's 2 hours, you feel hungry again. With these high glycemic index foods, it rises fast, comes down a little bit faster than the low glycemic index foods. But because it comes down faster, you start feeling hungry again. And that's where the danger of you eating more and overeating happens. Whereas the low glycemic index foods will fill your stomach, will not raise the blood sugar as much, see less than half here, and it will remain over the threshold for hunger level for more than 2 hours. So you don't feel hungry as soon as you do with higher glycemic index foods. Next one, please. Here are different foods that give you the idea of glycemic index. Here, look at the, I just want to read, I don't want to read all of them. I'll just give you some of them. White bread is 100, which is as good as the glucose itself. Then the baked potato is 85. Whole wheat, we say whole wheat is better. Whole wheat is better than the white bread, but it's still at high at 71. Then rice is at 64. Whereas if you look at the vegetables here, you find it very 15, 15, 15. Only the carrots is a little bit high, particularly the cooked carrots is a little bit high. Chickpeas. Then the fruits, you see the fruits are high too. Watermelon is 70. Pineapple. So these are the fruits diabetic people, diabetic individuals should avoid. Pineapple, banana, these are the fruits to avoid. Whereas apple, peach, orange, grape, they are low glycemic index. So they might be, it is preferred to have those kind of fruits. Then dairy, you have the dairy here, where you see the low-fat yogurt or the plain yogurt is having a glycemic index of just 14, which is even less than the vegetables that we talk. So you can have yogurt in your diet. And this is about the proteins. I was talking about the protein part in the beans. This is giving you the amount of proteins that you get from the peas or the beans. Next one, please. Again, it's a comparative scale, glycemic index values. Glucose is given 100. And here you see the different things, the spaghetti, white rice, white bread, things like that. And the vegetables are so low down here. Broccoli, spinach also will come down here. Lettuce will come here. Carrots will be somewhere in between. Beans are here, so low here. So they are low glycemic index and high in proteins. Next one, please. So the recommended portions in your plate, imagine your plate, this and how much you should have, the carbohydrate distribution, the vegetable distribution, the protein distribution, how should it be? This is recommended by American Diabetic Association or American National Institute of Nutrition as well, National Institute of Health. Your plate should be 25% or less of carbohydrates. 25% or 1/4 should be proteins, and 50% or half should be vegetables, fruits and vegetables. Here is fruits. And here we want to recommend you to do these combined together. If you do more of beans here, beans and legumes and greens here, you will get the proteins and the yogurt, get the proteins and get the calories too. So you may not even need the special carbohydrates like the potatoes and the rice and the bread. You may not even need that. Actually, if you don't eat that, that will help you improve your diabetes faster and keep you in the pre-diabetic or non-diabetic range most of the time. Next one, please. Here is some source for plant protein, all the beans. See how much proteins they have in half a cup of black beans, demi-greens or lentils, chickpeas, about 9 to 10 grams of protein that you get per half a cup. If you get 2 times of that, 2 cups will give you 30, almost 30, 40 grams of protein in this. And per meal, if you do 30, 40 grams protein, 2 meals will give you 70, 80 grams, which is the daily requirement by standard recommendations. You just get your protein requirement, you get your carbohydrate requirement, and your sugar levels will remain low. Next one, please. Again, these are different beans and lentils that the picture shows. Next one, please. So the diet to recommend is how much we should eat, what we should eat. The principle here I want to say is eat to live. That should be the principle and not the other way around. And the most important thing, the component of the diet should be beans and lentils, legumes, beans and lentils, vegetables, starchy vegetables with non-starchy and digestible and non-digestible fiber, dairy, particularly the yogurt, and water. Again, I want to mention about the water, 64 ounces of water, unless you have been restricted on fluids by your doctor. Next one, please. The next important thing about treatment of diabetes is exercise. If you have not started, if you are not doing it, do it, start. It's never too late. Start today, start tomorrow. It's never too late. Next one, please. The different types of exercise. People will tell you, oh, exercise 3 times a day or 3 times a week or 4 times a week, 5 days a week, 3 days a week, I do, is not enough. Is clearly not enough. If you have diabetes, then it is every day. My wife usually says this to her patients, that you don't ask me for a pill. Your exercise is your pill. So you take that pill every day. So exercise every day will help you. And clearly that helps. Next one, please. Different types of exercise, walking and also some weights. This particular slide I wanted to show because walking or cycling will give you exercise for the legs, but there are big muscles in the arm too, the shoulder muscles, the biceps and the triceps. So if you make the bigger muscles work, that will give you more exercise and glucose in the blood will be consumed more. And that's why, yeah, along with walking, if you do some exercise for the shoulders and the arms, then the weights, that will help you. Or those rubber bands that you have, you might have seen, most of you might be doing it as well. The TheraBands or the rubber bands, stretching your arms, stretching your shoulders, that will help making your biceps and the shoulders and the deltoids work, and increased utilization of glucose will happen. Next one, please. Now, this one particularly, I wanted to show you this. This is the actual graph of A1c of one of my patients. I'm going to discuss a couple of things about my patients here, actual patients. This particular individual was always hovering here between 7 and 7.5, hemoglobin A1c of 7.5, varying 3 months, 4 months, 6 months, just going up and down, going nowhere. So we kept talking, what should we be doing? What should we be doing? And here, when it went to 9, he really got disturbed. I know nothing, I have to do something, I must bring it down. So here we kind of talked about this, and then went through. Most of us, what we do is we have breakfast, lunch, and dinner, which is fine, but most of us have dinner as our largest meal of the day. And after that largest meal of the day, what we do, we are sitting together, family sitting together, having the meal together, we happy eating, and then eat the largest meal of the day, which could be about 1,000 calories, 800 to 1,000 calories, or maybe even more. And then what we do is sit on, watch TV, or just chat and go to sleep. We have done nothing. So this is what I talked to him, and we kind of said, okay, after every meal, particularly after meal, you walk. You do the walking after meal for 30 minutes, 40 minutes, 45 minutes. And this is what he did between, what is this, January 2021, March, that's when he was diagnosed, till July. This is 9, and this is 6.1. In these 3 months, 4 months, he came from A1c of 9 straight down to 6.1. Now, because of that euphoria, he was so happy, he went back up again because he didn't do that exercise. That's a different story, but it will come down. The point is, it will come down. Next one, please. So coming to the medications are as of today, they are an important factor of diabetes treatment. But my goal for patient treatment is, and what I want to say always is, eradicate, don't medicate. Control your diabetes, lower your A1c, lower the A1c, better the health condition, better the health status, and happier you are. There is always scope to do better. Never be satisfied. Never be satisfied with hemoglobin of 7, 6.5. Always try to be on the lower side. Next one, please. Here is the graph of typically this is what I use in my clinic to show to the patient where you belong. Most of the times they come here around 12 and then slowly come down. And most of the times they get stuck around this 8 and 9 and 10, which is still uncontrolled diabetes and is high risk situation leading to complications. The recommendation is to be in this, but personally, I recommend everyone to be here in the pre-diabetic range. Do whatever you can, eat right, do exercise, whatever you can, follow the diet, eat the beans and legumes, less rice, less wheat, less bread, less carbohydrates. You will be here in this pre-diabetes category. And that should be the goal of every single person who has diabetes. Next one, please. Finally, these are the list of medications, which all of you know. Next one, please. And the effect of medications. Intended effect is glucose control. Exaggerated effect is hypoglycemia. We talked about that. And side effect of medications is weight gain. Next one, please. This is the graph showing natural secretion of insulin at breakfast time, at lunchtime, and dinner time. And this is the basal insulin or fasting insulin, which the level of fasting insulin when increases, that's when the insulin resistance develops. And fasting is known to bring down the levels of insulin, thus decreasing the insulin resistance, which will help control the diabetes and improve your status as well. Next one, please. This is the principle of treating diabetes with insulin. This is the long-acting insulin or the basal insulin. And this is the mealtime insulin, that is at the breakfast time, before breakfast, before lunch, before dinner. Next one, please. Finally, goal with every individual should be to control and stay in the pre-diabetic range, in the healthy range. So my message always is stay active, stay healthy, and this is the slogan I use all the time: a bite less and a step more. I think that is the last slide that I have, and I think I kind of talked a bit too long, but you know, it is a topic where it's difficult to contain in less than 1 hour. So I'm sorry if I took a longer time, but that's all I have to say now.
No, doctor, I really enjoyed your session. म्हणजे थोडा जास्ती झाला तरी I think it was helpful. आणि मला हे म्हणायचंय की डायबिटीज सगळेजण ऐकून आहेत, पण the way you presented it, it was like all different pieces of puzzle coming together and we able to see the bigger entire completed puzzle. So that was very, very, very nicely done. Also तुमच्या प्रेझेंटेशन ऑन टॉक मधनं नक्कीच पुन्हा एक मेसेज बाहेर आला, ते म्हणजे प्रिव्हेन्शन इज द बेस्ट क्युअर. टेक सेल्फ कंट्रोल, टेक कंट्रोल ऑफ युअर सेल्फ हेल्थ. आणि त्याच्यासाठी तुम्ही जे काही आम्हाला ॲडवायजेस दिले किंवा सजेशन्स दिली ती इतकी सिम्पल शब्दांमध्ये होती आणि लॉट्स ऑफ ग्राफिक्सचा यूज होता, त्याच्यामुळे ते मेमरीत पक्क जाणार आहे. ॲज दे से राईट, पिक्चर स्पीक लाउडर दॅन द 1000 वर्ड्स. सो माझ्यासाठी आणि आय एम शुअर सगळ्या मेंबर्ससाठी हा सेशन खूपच इंटरेस्टिंग आणि हेल्पफुल राहिला. सो थँक्यू सो मच फॉर युअर टाइम आणि टेकिंग एफर्ट टू पुट दॅट प्रेझेंटेशन टुगेदर फॉर अस. पण डॉक्टर मला असं दिसतंय की 2 क्वेशन्स ऑलरेडी चॅटमध्ये आलेले आहेत.
Mhm.
ते मला बघू देत काय आहे आणि मी अजून म्हणजे लाईन्स ओपन करू जर कोणाला अजून काही प्रश्न विचारायचे असतील तर.
जरूर.
सो एक प्रश्न आहे पहिला, कॅन वी गेट द प्रेझेंटेशन स्लाइड्स? कॅन वी शेअर दिस विथ द ग्रुप मेंबर्स?
Yeah, I think so. That's fine.
Okay. आणि steroids increase the blood sugar. Is it true for Cartesian shots? Cartesian shots, she's asking.
Steroids in general do, and cortisone shots, even if they are local, we do see, because it's a high dose that is given, 40 milligrams, 40 milligrams at one time. And if it is a joint injection, it may not do as much, but it still does. The thing is, it may not last. Even if it is there, joint injections, cortisone injections, that can be a transient effect for a week or two.
थँक्यू. रेखाताई, तुम्हाला होपफुली आन्सर मिळालं असेल. रेखाताईंनी तो प्रश्न विचारला होता आणि जर अजून कुणाला प्रश्न असतील तर अनम्यूट करा आणि डायरेक्टली प्रश्न विचारू शकता तुम्ही.
हाय, मी नंदिनी विश्वासा.
नमस्कार.
ऐकू येतंय का मी
हो
बोलले?
हो ऐकू येतं.
हा, माझा प्रॉब्लेम काय आहे की डिनर नंतर मी 4 तासांनी जर ब्लड शुगर घेतली तर साधारण ती ऑलमोस्ट नॉर्मलला आलेली असते, म्हणजे साधारण माझी 120 पर्यंत असते. पण ह्याच्यानंतर माझी अशी अपेक्षा असते की सकाळपर्यंत ती आणखी खाली जायला पाहिजे, पण तसं न होता सकाळची माझी ब्लड शुगर 160 वगैरे अशी असते. Is there, what can I do for that?
Fasting blood glucose is an indication of higher intake of carbohydrates.
मी रात्री डिनर नंतर मग खाली कशी जाते, म्हणजे मी 4 तासांनी घेऊन बघते तर साधारण 120 वगैरे असते.
राईट.
So,
काय असतं हिअर, पोस्टप्रँडियल ग्लुकोज जेव्हा खाली जातं जेवल्यानंतर 1-2 तासांनी, बिकॉज इन्सुलिन गोज अप ॲज यू ईट, the blood sugar goes up, the graph is the insulin goes up too. And at some point the two meet and the insulin will bring the glucose down. And that gets stored in the liver and that becomes glycogen. So what happens is when it goes down to 120 or let's say 110, your body has been accustomed to 120 as a lower point, and the signals you get to release more glucose. So whatever is stored in the body as glycogen, we didn't have time to talk about that, which is stored as glycogen, that gets broken up and the levels start going up again. They go back up, and that's a classic situation of insulin resistance.
so what to do?
So fasting has been known to decrease the insulin levels. So 14-hour fast, 12 to 14-hour fast has been known to decrease the fasting levels of insulin and improve the insulin sensitivity in the individuals. And classically, in these individuals with higher resistance need to look at the BMI, need to address the BMI issue. Bringing down the BMI has almost always helped improve the insulin sensitivity. So
Okay.
that's one thing. And to do that, again, we'll have to go back to the diet, eliminate the carbohydrates from the diet, and try that kind of diet and exercise. You do more when we do more medications, we have the tussle between decreasing the BMI and improving blood sugar. There is always a tussle there. So the best thing, non-pharmacological thing that has helped so far is this, decreasing the blood glucose levels by decreasing the carbohydrates in the diet. Let me give you an example. We had one patient. He was 350 pounds. His blood A1c used to be 10, 9, 10, 9, 10, and blood sugar used to be 250 or like that. And I used to keep telling him, okay, don't eat potatoes, don't eat fast food, don't eat fast food. So every 3 months he kept coming, and we used to have similar kind of discussion, to the extent he got frustrated with me about that. He had an option between choosing the fast food and his doctor. He chose the second option of leaving the doctor and left. So 1 year later, he came back. I didn't recognize that person, because when he left me, he was 350 pounds. 1 year later, he came back, he was 175 pounds. Not taking any medications, not taking anything. And his weight at that time, 175, his A1c we did, it was 5.7, non-diabetic range A1c. He told me, doctor, you won't recognize me now, but this is what I did. You were yelling me all the time at me, saying, don't do this, don't do that. I got frustrated with myself, went and didn't come back to you, because I decided I'll come back and show you that I have improved. So what he did was, he stopped eating all that, whatever he was eating, the processed food, the junk food, and was walking every day for 10 miles every day. I'm not saying everyone should do that, but he was doing that 10 miles a day. Every single day he did that. He lost 170 pounds. He got rid of all the medications. His blood sugar was normal. His A1c was normal. And it remained like that for the next 2 years. No, he's off medications. He's off medications. He's off the blood pressure medications as well. He was on blood pressure medications too. That's also gone. So that much effect we have by diabetes, diet, and exercise.
Anyway, okay, I think I should. I can cut down on carbohydrates. पण किती कमी करून किती करणार का? I don't eat a lot of carbohydrates.
One thing I tell you, carbohydrates are not essential foods. So if you, apart from the craving that we have, because we have grown up with carbohydrates from our childhood, and carbohydrates are there everywhere in plenty, we keep eating those. We tend to eat those. And we think as if we cannot live without carbohydrates. No, we can. Carbohydrates, apart from giving you sugar, they don't give you anything. Potatoes can give you some proteins, but you can find proteins somewhere else too. Rice doesn't give you anything apart from starch. It's tasty, yeah, I agree about that. But apart from that, it doesn't give you anything. It gives you only carbohydrates and carbohydrates. So instead of that, just try like this. One day, everyday meal, one meal will be without carbohydrates. One meal without carbohydrates. One meal maybe with some carbohydrates. Try like that. Some of the patients we keep doing, okay, do fasting. Instead of 3 meals, do only 2 meals one day. Skip breakfast one day, skip lunch another day, skip dinner another day. So that way you go to 2 meals. There is a theory of that 2 meals a day, which helps. Because you skip one meal, naturally that meal, calories for that meal are gone, right? That many less calories we get.
Me try. Oh, sorry. झाला का टाइम अप?
नाही, मी फक्त एवढंच म्हणणार होते की डॉक्टरांनी जे आपल्याला सांगितलं की अमेरिकन स्टँडर्ड वर्सेस इंडियन स्टँडर्ड, ते खूप हेल्पफुल आहे, राईट? 1800 वर्सेस 1200, राईट? सो दॅट कम्पॅरिझन वॉज व्हेरी हेल्पफुल. आणि खूप सारी इन्फॉर्मेशन म्हणजे आपल्याला त्यांनी दिली, आणि ते स्लाइड्स पण आपल्याबरोबर शेअर करणार आहेत. सो मला असं वाटतं की त्या स्लाइड्स अभ्यास करून आपण आपली काय आपल्यासाठी पाहत आहे हे पण बघू शकतो. आणि डॉक्टर नंदिनी, ते मी एकच फक्त प्रश्न डॉक्टरांना विचारणार आहे की डॉक्टर, आमचे मेंबर्स तुम्हाला रीच आउट करायला त्यांना वाटलं तर रीच आउट करू शकतात का? कॉन्टॅक्ट्स आम्ही शेअर करू शकतो का?
माझा पर्सनल सेलफोन नको प्लीज.
नाही, तो नाही देणार. So whatever information, if you feel, we will share, maybe.
Okay.
आणि maybe I will talk to you offline on that. आणि
Sure.
ग्रुपकडे मी परत जाऊ शकते. नंदिनी ताई, आय एम सॉरी, मी तुम्हाला कट
That's
केलं
okay.
असेल.
Yeah, that's okay.
पण इफ यू जस्ट वॉन्ट टू फिनिश द थॉट, प्लीज डू सो, आणि मग आपण सेशन क्लोज करूया.
No, that's okay. Go ahead. I think I got the point what he's trying to say. So that's okay.
ओके. आणि वन्स अगेन थँक्यू सो मच डॉक्टर, आणि तुमच्या मिसेसला पण, कारण त्यांनी तुम्हाला मदत केली आहे. ते सगळे कॅलरीज काउंट आणि हे ते जी पिक्चर्स, ब्युटिफुल पिक्चर्स होती ती. आमच्या सगळ्यांतर्फे वन्स अगेन थँक्यू. आणि आम्हाला अजून काही सेशन्स तुमच्याबरोबर करायला आवडतील. वी विल डेफिनेटली गेट इन टच. प्रसाद, उल्का, दीप्ती, एनिथिंग ऑन युअर साइड?
No, it was indeed a good session, probably more informative. And as you said, we can have more sessions, and people can actually go through the slides, and we can connect them with Dr. Sambare whenever, or whatever contact, email or whatever number, office number he has.
परफेक्ट. थँक्यू. आणि मंडळी, आता मार्चमध्ये पुढचं सेशन येईल. स्टे ट्यून फॉर दॅट. वी विल बी shortly sharing the information about that.
Okay, thank you very much.